Yes. So, a very good evening, everyone. So, I welcome you all to this particular session of the previous year questions where there were images which have been asked in the general medicine. So, I'm myself, Dr. Rajesh Gubba. I'm the general medicine educator. So, in this session, I'll try to discuss what were the images that were asked in the previous year questions related to general medicine. The images may not be the same, but they are mostly the related images which I have kept. Okay. And before starting the session, let me just quickly tell you like what is going on an academy. So one of the very important offer in the Unacademy, and this is the last opportunity where the sale will be ending tomorrow, where you will be getting the iconic subscription, that is Unacademy and as well as Prep Ladder. You have very subsidized prices for 6 months, 12 months, and as well as the 24 months courses. And for the discount on these particular subscriptions, you can use my code, that is MED10, wherein you will get 20% discount on using my code. And the another important batch course which is about to start for the students who are appearing for the FMGE June 2023, right? June 2023. So this is a very important batch course which is starting, and this is totally a batch course of 5 months wherein you have this in 2 modules. Module 1 will be completely theory from February to April. Module 2 will be completely the pre-YQs and as well as image based sessions, and that will be from April to June. And this particular course is just only 15,300. And if you use my code, that is MED10, wherein you will get 20% discount on your subscriptions. And the other important course which is about to start in Unacademy is for next 2023 batch, right? So like this is the new course which is about to start from February 28th, and the duration of this particular course is around 8 months. So these are the batch courses which are going on Unacademy. So those students who are interested, definitely you can get subscribed to these particular batch courses, right? So having said this, now let us start the session. Yes, Samuel. So even though you are in UK, right, have the access of all these particular courses because these are all online. So even though you are from UK, you can access to these particular courses, right? So having said this, let me start with the first question, right? So this is the first question, that is, a 38-year-old man has come to see you because of some progressive gait difficulties, right? Some progressive gait difficulty. He has had several falls at home. On calling him through to your consultation room, you notice that his walk is abnormal, right? His walk is abnormal. Which of these features would be most likely to suggest a peripheral nerve problem as the cause of his walking difficulty? So peripheral nerve problem is there, and you can see how the gait of the individual is, and tell me like what exactly is this particular form of gait. Is it like broad based shuffling gait, circumduction of one foot, inability to turn quickly, rapid small steps with no festination, slapping one foot? Yes, any one of you please. Now the point is very clear here, that is peripheral nerve problem is there. So in patients with the peripheral neuropathy, just please remember the gait that you will have is the high steppage gait. The gait that you will have is called high steppage gait. And whenever there is a high steppage gait, like how the individual will be walking, he will be walking like in the form of slapping one foot immediately over the ground, and that is called as the slapping one foot. So the correct answer here is E, which is nothing but your high steppage gait. Now what about the other options? You take the broad shuffling gait. So where do you get this particular broad shuffling gait? That is in case of the cerebellar lesions. In cerebellar lesions, you get this broad shuffling gait. Then you take circumduction of one foot. Circumduction of one foot, you get this in case of the upper motor neuron lesion. Right, in upper motor neuron lesion, you get this circumduction of one particular foot. Okay, next, that is like pyramidal tract lesion or the lesion within the cerebral cortex, you get this circumduction gait. Then inability to turn quickly, that is what you get in case of Parkinsonism. Okay, in Parkinsonism you get this particular gait, and this particular gait we characteristically describe as the festinate gait, and even rapid small steps with no festination. Okay, so these are the rapid small steps with no festination. You come across this in case of the cortical lesions, right? You come across this in cortical lesions. And slapping one foot, this is what you will see in case of the peripheral neuropathy. So the correct answer here is slapping one foot. Now let me just show you quickly all the forms of the gait in one image. Okay, yes. So you can see here. So this is your spastic gait, which is nothing but circumduction gait, where you get this in case of upper motor neuron lesions. Then you take this scissoring gait. Where do you get this particular scissoring gait is, it is caused by high muscle tone in the hip adductors. So when there is spasticity within the adductors, that is the point where you get this scissoring gait. Next, your propulsive gait, this is what is your festinate gait, like you get in patients with the Parkinsonism. Steppage gait is nothing but you get in peripheral neuropathy. And waddling gait, see, waddling gait happens because of weakness in your hip girdle, right? It is, and in which conditions you get this particular waddling gait? That is in case of congenital hip dysplasia. So in congenital hip dysplasia, where you have weakness in your hip girdle, there you get this waddling gait. Okay, so these are the gait abnormalities, and the one which was asked previously was related to high steppage gait, which is seen in patients with the peripheral neuropathy, right? So having discussed about the gait, yes. Now this is one of the very frequently asked question, and no doubt it can be asked even once again as well. So a 65-year-old patient of coronary artery disease developed sudden onset right-sided, okay, sudden onset right-sided face and as well as the arm weakness, and there is also expressive dysphagia. On admission, the blood pressure is 160 by 100 millimeters of mercury. Non-contrast CT was done, and this is what is the image of the non-contrast CT. What is the best step in the management of this patient? Intravenous nicardipine, intravenous labetalol, retiplase, mannitol. So the question asked is the best step in the management of this particular patient. Now, what do you think is the correct answer in this question? Now, what exactly is this particular image suggestive of? This particular image, it is suggestive of the ischemic stroke, right? You have a hypodense lesion. Whenever there is a hypodense lesion, what is this suggestive of? The ischemic stroke. Now, where exactly is this particular ischemic stroke present? It is present within the left MCA territory, right? It is present within the left MCA territory. Now, he did not give you the duration of the weakness, but what he has given is sudden onset. Okay, so what do you think would be the best management in this particular patient? That is your thrombolysis, that is intravenous retiplase has to be given. Now this particular retiplase, like what is the dosage that you will give? The dosage of your thrombolytic agent is around 0.9 milligram per kg body weight. So out of which 10% you will give in the first minute and remaining 90% you will give within the 60 minutes. That is how you will do the intravenous thrombolysis. Okay, now what about the first two options, that is nicardipine and as well as labetalol? Now the blood pressure of the patient is just only 160 by 110 millimeters of mercury. It is not a hypertensive crisis. It is not a hypertensive crisis. So your nicardipine and labetalol are not required, as BP is not in the range of the hypertensive crisis. And lowering this BP value will reduce cerebral perfusion and worsen the ischemia. So that is the reason why nicardipine and labetalol are not required. Now, what about the mannitol? Yes, mannitol is given when features of raised intracranial pressure are present. But what is the question asked? What is the best step in the management of the patient? So the best step will be the retiplase. So that is the reason why the answer is being C. And no, see, if you take the Gokul Krishnan, a very good question by Gokul Krishnan. See, whenever you, what is one of the very important indication for thrombolysis should be like the ischemic area, that is the hypodense area should not be more than one third. If the ischemic area, if it is more than one third, we should not do thrombolysis. Now, if you take this, the entire cerebral cortex, if you take this as the entire cerebral cortex, that particular area which is being affected, it does not look like contribution to more than one third. So that is the reason why the preferable treatment is thrombolysis here. Okay, right. So having discussed about the second important image, next we'll move on to the next image. Yes. Now after Kapil Pathak, Kapil, see this patient is in ischemic stroke, and that too the blood pressure is just 160. So don't try to reduce the blood pressure at this point now. Don't try to reduce the blood pressure at this point now, because that will further cause the precipitate the underlying ischemia. Okay, right. Now you see the next question. Endocrine disorder with the following presentation: acromegaly, Cushing syndrome, Addison's, hypothyroidism. This is like one of the very important asked previous year question. Almost 2-3 times this particular question was asked. Endocrine disorder with the following presentation: acromegaly, Cushing syndrome, Addison's, and hypothyroidism. Very good Gokul question. So the answer is the hypothyroidism. Now what is that you are observing here very carefully is, so you can notice very clearly that there is cardiomegaly, right? And the classical appearance, if you see, that is of the money bag appearance, and this classical money bag appearance, if you see, this is suggestive of the pericardial effusion. Now among the options which has been given to you, which endocrine disorder you can have the pericardial effusion, that is hypothyroidism. So that is the reason why the answer is being hypothyroidism, right? Yes, Sahil Jain, yes, one of the very important differential diagnosis that you can consider is your acromegaly, but in acromegaly you will have cardiomegaly, but you don't have this particular water bag appearance in case of the cardiomegaly secondary to your acromegaly, right? Now one more endocrine condition. This was the one of the toughest question which was there, right? A clinical scenario was given, but finally the gist of the question was like this: in which of the following men syndromes this condition is seen? Men 1, men 2A, men 2B, men 4. Men 1, men 2A, men 2B, men 4. Right, very good. So it is seen in case of the men 2B. Men 2B is also called men 3, which is nothing but your Wagenman Frobois syndrome. What exactly you are seeing here is the presence of the mucosal neuromas. Right, the presence of the mucosal neuromas. So the condition where you will have this which type of men syndromes you have this mucosal neuromas is nothing but in case of men 2B, which is also called as men 3. And what are the extra endocrine manifestations in men 3 apart from mucosal neuromas? They also have marfanoid habitus. And what are the endocrine manifestations in men 3? They will have medullary carcinoma of thyroid and as well as the pheochromocytoma, right? So here the answer is the men 2B, which is also called men 3. Next, then you see the next question. Right, a 58-year-old man undergoes severe head trauma and develops pituitary insufficiency. After recovery, he is placed on thyroid hormone, testosterone, glucocorticoids, and vasopressin. Right, on routine visit he questions his primary care physician regarding potential growth hormone deficiency. All of the following are potential signs and symptoms of growth hormone deficiency, except which is the incorrect statement. Yeah, Kapil, you want the men to be described briefly? Yeah, okay, I'll just show you the men. Just give me a minute, let me complete this question and then we'll move on to quick discussion of the men. Right, very good. So now whenever there is a growth hormone deficiency, you will not have increased bone mineral density. So whenever there is growth hormone deficiency, there will be decreased bone mineral density. The remaining all, abnormal lipid profile, atherosclerosis, increased waist hip ratio, left ventricular dysfunction, all that will be there in case of growth hormone deficiency. But increased bone mineral density will not be there. There will be decreased bone mineral density. Okay, so please remember this is a very important point. Next, now if you take this men syndromes, okay. So as Kapil was asking quickly, let me just quickly recap. So you take men 1. So men 1, what exactly is the another name for men 1? This is also called as the Wermer syndrome. And you have to remember 3 P's of the men 1. That is pituitary adenoma, parathyroid adenoma, and as well as the pancreatic tumors. And you also have the extra endocrine manifestations in the form of the carcinoids. Then you take men 2A. Right, and in case of men1, the gene which is being mutated is the men1 gene. And where exactly is this men1 gene present? It is present on the chromosome 11. And you take your men2A and as well as men2B. in both of them, the gene which is being mutated is the RET proto-oncogene, and in MEN2A, please remember the mnemonic, that is PAT, that is parathyroid adenoma, adrenal pheochromocytoma, and thyroid abnormality will be in the form of medullary carcinoma of thyroid. Then you take MEN2B, yeah, RET proto-oncogene, which is present on chromosome 10. And in case of MEN2B, like you just only have the AT, that is adrenal pheochromocytoma, and then thyroid, that is medullary carcinoma of thyroid, right? And your MEN2B is also called Wagenman-Frobois syndrome, and MEN2A, it is also called as the Sippel syndrome. And then you also have MEN4, right, where the gene which is being mutated is CDKN1B. Right, and this CDKN1B is present on chromosome 12, and in case of your MEN4, you also the individual will have reproductive organ tumors. That is, in males there will be testicular tumors, and in females there will be cervical tumors. So this is quick recap of all the MEN syndromes. Right, now, after having discussed about this particular question, like what is that which you don't see in case of growth hormone deficiency, you will not have increased bone mineral density. What is that you will have is decreased bone mineral density. Now, the another very important area of your questions which have been asked previously was the flow volume loops. Right, the another important PYQ was the flow volume loops. Now, the pattern shown on the flow volume loop is the obstructive pattern, restrictive pattern, normal curve, mixed pattern. So what do you think is the correct answer here? Right, so if you very closely observe, yes, so it is your obstructive pattern. Now, see, this is the normal flow volume loop that it should be. But what has happened here, right, if you see very clearly, right, the expiratory pattern is reduced, the expiratory component is being reduced. So once the expiratory component is being reduced, like that is nothing but your obstructive lung disease. Now I'll just show you one more flow volume loop, right? So everyone is aware this will be the inspiratory component and this will be the expiratory component, and what has been reduced there? Expiratory component is reduced. So expiratory component is being reduced in patients with the obstructive lung disease. Okay, please remember this is a very important point. Now, one more flow volume loop that you need to remember is, yes, this one. Right. So this particular flow volume curve shows COPD, interstitial lung disease, variable extrathoracic obstruction, variable intrathoracic obstruction. Now, what is the condition where you will have this? Yes. Right, very good. So this is seen in case of the variable extrathoracic obstruction. Now, one of the example of your variable extrathoracic obstruction is retrosternal goiter. One of the examples is the retrosternal goiter. Now, what happens is this particular retrosternal goiter, which is a lesion, it is being sucked down along with the trachea during inspiration. So that is the reason why the inspiration in case of retrosternal goiter will be reduced, right? Because that particular goiter will compress the trachea, causing partial obstruction and thereby flattening the inspiratory part. And during expiration, what will happen? It is a passive expiration occurs. So during expiration, the goiter moves up, the expiration will be normal. So that is what is the flow volume loop of variable extrathoracic obstruction. Then, like, what about how will be the flow volume loop in case of variable intrathoracic obstruction? See, one of the very important example of your variable intrathoracic obstruction is the laryngeal tumor. So in case of laryngeal tumors, yes, this is how the flow volume loop will be there in case of variable intrathoracic obstruction. So in case of intrathoracic obstruction, please remember the inspiratory component will be normal, but it is the expiratory component that will be reduced, right? And finally, you should know, like, what will be the flow volume loop in case of the fixed obstruction. What are all these? Variable extrathoracic and variable intrathoracic obstruction. Whereas if you see in case of, right, whereas if you see in case of the fixed obstruction, right, in case of the fixed obstruction, like what is the example of the fixed obstruction? That is nothing but your tracheal stenosis. So in case of tracheal stenosis, both of them will be reduced. Expiration will be reduced and as well as the inspiration also will be reduced. Okay, so this is about the story of your flow volume loops, right? So this is one of the very important area in the pulmonology where the questions will be asked regarding the image based questions, right? So this is an integration of the pharmacology and general medicine. This is the integration of the pharmacology and general medicine. Okay, so a 42-year-old woman presents with pink-red macules of the face, palm, soles. She had multiple sexual partners. After she is treated with an antibiotic, there is development of fever, hypotension, and worsening of rash that has been developed. Which one of the following occurred? Drug allergy, sepsis syndrome, Jarris eczema reaction, angioedema, Steven Johnson syndrome. Right. So, like now, what exactly is this? It is the Jarris eczema reaction. So, this Jarris eczema reaction occurs within 1 to 2 hours of treatment of syphilis with antibiotic, that is especially penicillin. So, multiple sexual partners. So, one of the very important sexually transmitted diseases is syphilis, for which the antibiotic that we give is the penicillin. So, whenever you give this particular penicillin in certain group of individuals, within 1 to 2 hours, they can develop this particular abnormality, which is called as the Jarris eczema reaction. And you have to remember that this particular Jarris eczema reaction is most common during the treatment of secondary syphilis. This is a very important point. So during the treatment of secondary syphilis, you get this particular Jarris eczema reaction most commonly. That is nearly seen in around 70 to 90% of individuals. Now, what are all the features of Jarris eczema reaction? Fever, chills, headache, hypotension, worsening of the skin lesions. Then how do you treat this? So it is only supportive therapy, right? The treatment or the reaction usually resolves within 24 hours of the treatment. It is just only supportive treatment. Okay, right. So right, yes, Varun, the answer to your question is most commonly seen in secondary stage of your syphilis. Can be seen in other stages, but most commonly in the secondary stage of syphilis. Okay, right. And yeah, what kind of hypersensitivity reaction do you think it is? Now, so like you take the acid, that is your type 1, 2, 3, 4. So it is an allergic component which is getting initiated. Right, it is an allergic component which is getting initiated. So this will be your type 1 hypersensitivity reaction. Okay, right. Now, then moving to the next question. It is not delayed, right? See, it is occurring within 1 to 2 hours. Within 1 to 2 hours. So when it is appearing within 1 to 2 hours of taking this particular penicillin, so why the question of your type 4 comes? Okay, type 4 doesn't come. Okay, now you see the next question. The next question is, an 82-year-old man presents with 8 weeks history of the periorbital edema, 6 weeks of rash, 2 weeks of bilateral shoulder and arm aches and weakness. What do you think is the diagnosis? Polymyalgia rheumatica, inclusion body myositis, hypothyroidism, polymyositis, dermatomyositis. Right. What is the correct answer here? No. It is not polymyalgia rheumatica. Right. See, in polymyalgia rheumatica, you have this particular bilateral shoulder and arm aches. That is accepted in polymyalgia rheumatica. But in polymyalgia rheumatica, you don't have this periorbital edema. You don't have the rash. You don't have the proximal muscle weakness. So, no. So this is very classically seen in case of, now it is not the hypothyroidism. See, in patients with hypothyroidism, what is that you will have is, you have that moon-shaped face. You don't get this periorbital edema. So this is a classical presentation in patients with the dermatomyositis. So in dermatomyositis, along with the skin manifestations, there will be proximal muscle weakness. Right? There will be proximal muscle weakness, and this dermatomyositis, it is an autoimmune disorder, right? It's an idiopathic inflammatory myopathy, and it's an autoimmune disorder. And the other name for this dermatomyositis, like we can also call this as the inclusion body myositis. Inclusion body myositis is also one of the inflammatory myopathy, right? Now, what are all the various skin changes that you will see in patients with dermatomyositis? This is a very, very important area for your image-based questions. Now, let me show you what are all the various skin abnormalities. One is your heliotrope rash, which is present around the eye and as well as over the malar areas, right? Then, presence of the Gottron papules that are present over the knuckles. And next is the erythema of the upper chest. And that is what is nothing but your presence of the V sign. That is nothing but the presence of the V sign. Okay. Then next is the presence of the shawl sign. This erythema is present even over the place where we usually place the shawl, and that is the reason why it is also called shawl sign. And over the fingers, there will be dilatation of the capillaries within the digits, and that we call it as periungual telangiectasias, that we call periungual telangiectasias. And another important skin abnormality in dermatomyositis is the hand. How will be the hand of these individuals? Like mechanic's hand. And the calcium will be deposited within the skin, within the fingers, and that we call it as calcinosis cutis. So these are all the dermatological changes that you will see in patients with the dermatomyositis. And in dermatomyositis, as I have said you, it's an autoimmune disorder. What is the antibody that you will have? That is the anti-Jo1 antibody, and it is not only skin, there is also the myopathy. So thereby what will happen to your serum creatinine kinase levels? The serum creatinine kinase levels, they are being elevated. Then how do you treat these patients? See, whenever you do a muscle biopsy will show you the presence of inflammatory myopathy. But what will be the treatment for your dermatomyositis? The treatment for dermatomyositis is you need to give steroids, that is the immunosuppressive therapy. Okay, so this is about your dermatomyositis, right? Now these are all the important images which have been asked previously, right? So now this particular PDF I will send you to my Telegram channel immediately after the class, that is Medicine Made Easy by Dr. Rajesh Gubba, right? You can join my channel Medicine Made Easy by Dr. Rajesh Gubba, so wherein I'll be sending you this particular PDF on my Telegram channel. Okay, right? So having said this, we'll move on to the next question. Right, yes, Gokul Krishnan, in case of polymyositis, okay, let me take up the other options as well. In case of polymyositis, you have only muscle involvement. Skin abnormality will not be there in case of polymyositis. And in hypothyroidism, like as I have said you, in hypothyroidism you will have that moon shaped face, you don't have this particular periorbital edema. Then you take this inclusion body myositis. Just now I was telling you about this inclusion body myositis. This is also one of the idiopathic inflammatory myopathy, right? Inclusion body myositis, it is also called in idiopathic inflammatory myopathy. And polymyalgia rheumatica, you will have stiffness of the shoulder girdle and as well as the hip girdle. And this polymyalgia rheumatica, most commonly it is associated with your temporal arteritis, which is nothing but your large vessel vasculitis. Okay, right. Now, yes, Obito, your inclusion body myositis, it is a form of the idiopathic inflammatory myopathy, right? Where there will be the inclusion bodies which are present within the proximal muscles, that is the proximal muscles of your upper limb and as well as the lower limb. Okay, right. So having said about this, we'll move on to the next important image. Right, so please answer this. So these are the hand and skin findings of 26-year-old women who complains of the early satiety. That point is very, very important. Okay, early satiety. Her past medical history is notable for upper gastrointestinal bleeding and as well as the rectal prolapse. What is the diagnosis? Ehlers-Danlos syndrome, cutis laxa, osteogenesis imperfecta, congenital contractural arachnodactyly. Right, so very simple and very easy question, that is the Ehlers-Danlos syndrome. Now if you take this Ehlers-Danlos syndrome, what exactly is this? It is a connective tissue disorder, and you have many forms of Ehlers-Danlos syndrome, up to 15 types you have, it is an inherited disorder. Most commonly it is autosomal dominant type of inheritance. And what exactly will be the problem in these individuals? You will have the hyperextensible and lax joints. Okay, and the skin also, if you see, you get this particular velvety texture, right? And what are the important abnormalities? Multi-system involvement will be there. Gastrointestinal abnormality in the form of rectal prolapse and gastrointestinal bleeding, and there will be visceral diverticulosis. The cardiac involvement will be in the form of mitral valve prolapse and dilatation of the aortic root. And if you take the foot of these individuals, they'll have pes planus. And if you take the spine of these individuals with Ehlers-Danlos syndrome, they'll have this scoliosis. And if you take the lungs of these individuals, there can be development of pneumothorax, and there will be also dilatation of the pulmonary artery. So these are all the manifestations that you will come across in patients with the Ehlers-Danlos syndrome. Now, having said about the Ehlers-Danlos, we'll move on to the next question. Right. So a patient with HIV, right, has had a rash in association with trimethoprim sulfamethoxazole used as prophylaxis for pneumocystis carinii pneumonia. An alternative medication was used, but the patient took 3 times the normal dose by mistake. Okay, he became dyspneic and headache, nausea and vomiting, and skin discoloration shown here developed. Okay, so this is the normal hand and this is the discolored hand. What was that alternative medication? What was that alternative medication? Pentamidine, pyrimethamine sulfonamide, atovaquone, dapsone, clindamycin, primaquine. Uh, no. It is not clindamycin primaquine. We have one student answering it correctly. That is Gokul. Very good, Gokul. This is dapsone. Dapsone. It is not clindamycin primaquine. Now, so you take this abnormality. What exactly is this abnormality? It is methemoglobinemia, right? It is methemoglobinemia due to dapsone overdose. And what exactly is your methemoglobin? Methemoglobin is that where you have the ferric form of hemoglobin that cannot bind with oxygen. What do you mean by the ferric form? That is your Fe+3 that cannot bind with the oxygen, right? So although sometimes inherited, it is more often formed by the oxidative stress. And among the drugs, okay, among the drugs, your dapsone is one of the very important drug. And because of methemoglobinemia, like what exactly will be the feature? See, the color of the skin and what will be the discoloration of the skin, we describe this as, that is chocolate brown or slate blue cyanosis, and this is unrelieved, right? And this is unrelieved with oxygen. It is unrelieved with oxygen. That will suggest the diagnosis of the methemoglobinemia. Then how do you treat these patients with methemoglobinemia? Can anyone tell me what is the antidote for methemoglobinemia? Yes, what is the antidote in case of methemoglobinemia? So please remember, whenever the individual is having severe hypoxia, what you need to give is, you need to give methylene blue, right? You need to give methylene blue. That is the antidote that we give in case of the methemoglobinemia. So whatever you are seeing here, this particular methemoglobinemia, it is secondary to dapsone overdose, and dapsone is one particular drug which can be given for the treatment of your PCP, right? Now, having said about the story of PCP, we'll move on to the next question. Okay, so a 47-year-old missionary has lived in India for 15 years. The lesions shown here are painless and numb and developed over about 6 months time. Which of the following is the part of the first line treatment regimen for this particular patient? Glucose control, dapsone, gabapentin, topical corticosteroids, itraconazole. So the points are very clear here. So what is that? Number one, missionary, 47-year-old missionary. Lesions are painless and numb, right? And you can see that hypopigmented patches, okay, and which are like no sensations present. So what exactly is this particular diagnosis suggestive of? No. What is the diagnosis? So those students who have answered dapsone, what do you think is the diagnosis here? Very good. So diagnosis here is the leprosy. Right, diagnosis here is the leprosy. So what exactly is the organism? That is the Mycobacterium lepra. Mycobacterium lepra. And you have two forms of leprosy. One is your tuberculoid leprosy and the other one is lepromatous leprosy. So in tuberculoid leprosy, you will have marked hypopigmented, anesthetic, sharply demarcated macules. Hypopigmented, anesthetic, sharply demarcated macules. And nerve involvement may lead to muscular atrophy in case of tuberculoid leprosy. But whereas you take in lepromatous leprosy, there will be extensive cutaneous involvement with diffuse granulomatous macules, papules or nodules. That is what you will have in case of lepromatous leprosy, right? And what will be the abnormality within the extremities? You will have the claw hand, and even you see the foot, there will be foot drop, there can be claw toes. So these are all the abnormalities that you will see in case of the leprosy. And what do you think is the first line treatment? The first line treatment will be the dapsone. And this particular dapsone is given along with rifampin. The other alternative drug is the clofazimine may be added. Okay. So the correct answer here is Right, the correct answer here is the dapsone. So you should be able to identify that the individual is having hypopigmented patches and as well as the painless lesions. That is what is suggestive of leprosy. And if you don't diagnose that it is leprosy, then you will not identify the answer as the dapsone. Now we move on to the next question. Yes, this is another very interesting question. So the cutaneous finding shown is most commonly associated with which one of the following medication? Ciprofloxacin, amantadine, hydrocortisone, verapamil, ibuprofen. Yes. So what exactly is the diagnosis there? What exactly is the diagnosis? Right. So the diagnosis is the livedo reticularis. So what exactly is your livedo reticularis? Livedo reticularis manifest in a net-like mottled pattern with a bluish discoloration. Right, so it may be deep blue in cold environments, and most commonly this particular livedo reticularis is seen on the lower extremities. Most commonly seen on the lower extremities. Right, now what are all the drugs that can cause this livedo reticularis? That is your amantadine. Right, that is amantadine. And what are the other conditions where you can have this, the livedo reticularis? The other conditions are cryoglobulinemia, anticardiolipin antibody syndrome, polycythemia vera, polyarteritis nodosa. So in all these conditions, you can have this, the livedo reticularis. And the medications are amantadine. Can anyone tell me what are the other medications apart from amantadine? The other medications which can cause is your quinidine. Right, quinidine and as well as quinine. These are the other medications which can cause this livedo reticularis. Okay, right. And one more important condition where you can have this livedo reticularis is in case of the cholesterol embolization after cardiac catheterization. Right, after cardiac catheterization, there will be development of the cholesterol embolism. So even in case of cholesterol embolism, you can have this livedo reticularis. Okay, and what does the treatment includes? The treatment includes the management of the underlying cause and avoidance of cold exposure. That is what you have to do in case of the livedo reticularis. Okay, right. Now after having discussed about the livedo reticularis, let me just take up the next important image. Right, so a patient presents with tibial bowing and complains of the hearing loss. What is the most common complication of the disease affected this patient? Pulmonary fat embolism, congestive heart failure, hypercalcemia, traumatic bone fractures, the aortic dissection. So you should be able to identify what exactly is the abnormality here. So a patient presents with tibial bowing, complaining of hearing loss. What is the most common complication of the disease affecting this patient? Right. So first of all, you should know what is the diagnosis which is being here. Right. The diagnosis is the Paget's disease. The diagnosis is the Paget's disease. Okay. See, Paget's disease is characterized by disorganized bone remodeling and bone pain. Right. Disorganized bone remodeling and bone pain. And bones involved by Paget's typically have 3 stages of evolution. What is the 3 stages in Paget's? Lytic phase will be there, transition to mosaic pattern, and then sclerotic phase will be there. These are the 3 phases. And the most common symptom is the focal bone pain. The most common symptom in Paget's will be the focal bone pain. Now in patients with the Paget's, there will be tibial bowing, there will be hearing loss, and in these individuals there will be traumatic bone fractures. In these individuals there will be traumatic bone fractures. Now why is this particular hearing loss that you are having in case of the Paget's? See, the hearing loss may be due to involvement of the inner ear ossicles. Right, so you have malleus incus stapes. Right, that is miss. So that inner ear ossicles may get affected in case of Paget's, and that is what is responsible for the hearing loss. Right, and what is the first line treatment in patients with the Paget's? The first line therapy is the anti-resorptive medications. And what is that anti-resorptive medications that we need to give is bisphosphonates. Right, and you have 2 answers in this particular question. One is your traumatic bone fractures, and the other important is the hypercalcemia. Right, even your hypercalcemia is also correct. Right, even hypercalcemia could also be correct. Okay, so 2 answers you have in this. Right, and which is suggestive of your the Paget's disease of bone. And why is this particular Paget's? One, you have tibial bowing and as well as the hearing loss. Right, now after having discussed about this, we'll move on to one of the image based paused on the, yes. Now, so this is a 18-year-old man is distressed about the intermittent abdominal pain he has been experiencing for the past several months. Results of barium enema examination are shown here. This syndrome of intestinal polyposis is also associated with which of the following? This syndrome of intestinal polyposis is also associated with which of the following? Any one of you? Right, very good. So the correct answer is macular pigmentation of the oral mucosa. Now, can anyone tell me what is the diagnosis of this clinical condition? Now, what is the diagnosis of this clinical condition? Very good. So, diagnosis is your PJS, that is Peutz-Jeghers syndrome. Now, Peutz-Jeghers syndrome, what exactly is this? It is an autosomal dominant disorder which is characterized by the presence of the hamartomatous polyps in the gastrointestinal tract. Right, and genetic penetrance in families is reported to be as high as 90% because it's an autosomal dominant type of inheritance. And if you take this particular polyps in case of the Peutz-Jeghers syndrome, they are large and as well as the pedunculated, right? They are large and pedunculated. Now, if you take the frequency of this particular polyps, the frequency of these polyps, they are very common in the small bowel, followed by that large bowel, followed by that in the stomach. Now, what do you think will be the associated cutaneous lesion? The associated cutaneous lesion in patients with the PJS will be macular pigmentation of the oral mucosa, that is the lips and as well as the periungual skin. The periungual skin and as well as the pigmentation of the lips. So that is what is your the Peutz-Jeghers syndrome. And what will be the clinical manifestation? That will be recurrent abdominal pain. And this particular recurrent abdominal pain may be due to partial obstruction from the polyps. Right, partial obstruction from the polyps. And what is the abdominal emergency that can be seen in patients with the Peutz-Jeghers syndrome is there can be development of the valvulus. There can be development of intussusception. That will be the abdominal emergency that can be seen in patients with the Peutz-Jeghers syndrome, right? Now, apart from the intestine, in Peutz-Jeghers syndrome, the polyps can be present in the extraintestinal sites also. The polyps can be present within the nose. The polyps can be present within the uterus, respiratory tract, urinary tract, and as well as the gallbladder. So these are all the places where you can have the presence of the polyps in patients with the Peutz-Jeghers syndrome, right? So these patients, they'll have the skin manifestation in the form of macular pigmentation of the oral mucosa, right? Yes, you see the next question. Okay, now this is another important image based question which was asked previously. A 69-year-old man presents with acute severe headache. Physical examination, right? Physical examination reveals an isolated left third cranial nerve palsy. Isolated left third cranial nerve palsy. Laboratory studies shows hyponatremia, abnormally low levels of luteinizing hormone, follicle stimulating hormone, thyroid stimulating hormone, ACTH, testosterone, thyroxine, cortisol. What exactly is the diagnosis in this condition? Yes, see, in rheumatoid arthritis, hypogonadism is because of the inflammatory pathology. See, rheumatoid arthritis, you don't have not only articular manifestations, you also have extra-articular manifestations. And that autoimmune antibody, that is your anti-CCP and as well as RA factor, will go and destroy the seminiferous tubules within the testicles. And thereby, the individual can develop hypogonadism. Right, so here the correct answer is the pituitary apoplexy. Right, here the correct answer is the pituitary apoplexy. Now, the patient is, what are the points suggestive of your pituitary apoplexy? One of the very important points suggestive of your pituitary apoplexy is your acute severe headache. Right, and what exactly is your pituitary apoplexy? The pituitary apoplexy refers to hemorrhagic infarction of the pituitary gland. Now, what are the predisposing conditions? The predisposing conditions include the predisposing conditions for your pituitary apoplexy. The predisposing conditions for your pituitary apoplexy, that includes the presence of an underlying pituitary tumor, irradiated pituitary tumor, pregnancy, anticoagulation therapy, increased intracranial pressure, vascular diseases like vasculitis. So these are all the features which are the predisposing factors for the development of pituitary apoplexy. And what will be the clinical presentation in patients with pituitary apoplexy? Severe headache and ocular palsy. Ocular palsy, and you can see here there is severe third cranial nerve palsy, and that is the reason why the individual is having ptosis. That is the reason why the individual is having ptosis. Okay, so these are the features of the pituitary apoplexy. Now, not only that, how can you tell that the pituitary is being gone? Because all other hormones are reduced related to your pituitary. What are all the other hormones which have been gone? Luteinizing hormone, follicle stimulating hormone, TSH, adrenocorticotrophic hormone, testosterone, thyroxine, cortisone, everything is gone. So that is also the point which is telling you that there is hypopituitarism. There is development of hypopituitarism. So this is what is your pituitary apoplexy. Right now, yeah, like whenever, so what is this particular apoplexy? Yes, Sana. So it is a hemorrhage, right? It is the hemorrhage. So whenever there is a hemorrhage, like what is that you will observe, or what is that you will notice? You will notice the presence of the hyperdense lesion. Right, it is the presence of the hyperdense lesion. So like if you clearly observe, so here you have the presence of the hyperdense lesion, which is suggestive of your pituitary apoplexy, right? So that was about the image related to pituitary apoplexy. Right, now one of the other important asked question is this. Okay, right, so the findings shown here are those for a 52-year-old man 6 months after liver transplantation. 6 months after liver transplantation. Which statement is true about this infection? It develops in patients with the humoral immunodeficiencies. It may be definitively diagnosed with serological IgM assay. It may be effectively treated with itraconazole. It is transmitted by aerosolization, characterized by broad-based buds. Yes. What exactly? Yeah, Kapil, why third nerve palsy is because of your pituitary apoplexy, that is because of your hemorrhage. Like what is happening is like the cranial nerve which is adjacent to that pituitary can get compressed, and one of the cranial nerve which is being present adjacent to your pituitary is your oculomotor nerve, which can be compressed, resulting in your third nerve palsy. Okay, right. So what do you think is the correct statement here? So the patient is on, see, 6 months after liver transplantation. So 6 months after liver transplantation, what does that mean? That means the patient will be on the immunosuppressive therapy. The patient will be on immunosuppressive therapy. So when the patient is on immunosuppressive therapy, the immunity of the individual will be reduced. So the patient is more prone for the fungal infection. And which is the fungal infection which is very commonly seen in a scenario of the immunocompromised state? The scenario of immunocompromised state, what you get is the cryptococcus. Right, it is your cryptococcus, right? That is cryptococcus neoformans, and this cryptococcus neoformans exists as the free living fungus where within the soil and as well as even within the avian excreta you get this cryptococcus neoformans. And how is it being transmitted? It is transmitted by the aerosolization. It is being transmitted by the aerosolization. So inhalation of the aerosolized organism is the mode of transmission of this cryptococcus. And where exactly will be this cryptococcus? This cryptococcus will be there within the soil and as well as the avian excreta, right? And this cryptococcus is a opportunistic infection in patients with cell mediated deficiency. Now this patient has undergone liver transplantation, so he will be definitely on immunocompromised immunodeficiency therapy or immunosuppressive therapy where the immunity of the individual will be reduced. So that is the reason why the individual is prone for your cryptococcal infection. Now, because of this cryptococcal infection, what all the manifestations can be there? There can be development of pneumonia, there can be development of meningitis, there can be also the cranial nerve infiltration. And what is the definitive test? The serological test. The serological test of choice, that is cryptococcal antigen test, right? Cryptococcal antigen test. Now, what is this particular stain which is being used here? The stain which is being used is the India ink stain. This particular India ink stain may show the yeast-like organism with narrow-based buds. With narrow-based buds. And CNS disease should be ruled out in patients with neurological symptoms and in immunocompromised patients, right? So then how do you treat these patients? See, like if it is CNS cryptococcosis, if it is CNS cryptococcosis, like what is the drug that you give? You give the amphotericin B. It is not your itraconazole. We give amphotericin B. And if it is non-CNS cryptococcosis, then what we give is the fluconazole. What we give is the fluconazole. Okay, right. So it may be definitive diagnosis. No, it is not IgM. It is your cryptococcal antigen test. Right, characterized by broad-based buds? No. Like how will be the buds here? In the India ink stain, it will be narrow-based buds. Now it develops in patients with human immunodeficiencies. Okay, it can be seen in the human immunodeficiency viral infections. Okay, human immunodeficiency viral infections, not in case of the human immunodeficiencies. Human immunodeficiency viral infections, you can have this cryptococcus. So that is the reason why. What is the correct answer here? The correct answer is it is transmitted by the aerosolization, right? Now, the other important question, integrating ophthalmology and general medicine. Yeah, okay. Yes, Obito, you're right. That is LAMB. Liposomal amphotericin B for cryptococcal meningitis and non-CNS cryptococcosis, like what we give is fluconazole. Okay, right. We'll move on to the next question. A 58-year-old man with no significant past medical history except for hypertension. Okay, 54-year-old hypertension controlled with medication presents with acute mild pain and redness of the eye. The redness, okay, the redness involves only a portion of the eye. You can see that here. The redness involves only the portion of the eye. He otherwise feels well and reports no other symptoms. How should this condition be treated? Observation only, topical steroids, topical antibiotics, topical beta adrenergic receptor antagonist, corneal transplant. So what exactly is the diagnosis here? What exactly do you think is the diagnosis of this particular image? So like it is the episcleritis. The image whatever you observe here is the episcleritis. Now this episcleritis is due to acute inflammation immediately underlying the conjunctiva. Right, it is due to acute inflammation immediately underlying the conjunctiva. And this particular episcleritis, please remember, it is self-limited. It is self-limited, right? And next to this observation, what would be the next best answer? Although topical non-steroidal anti-inflammatory drug, it is not steroids. Topical non-steroidal anti-inflammatory drug may hasten the resolution. Otherwise, episcleritis is the self-limited. Okay, most patients with episcleritis do not have any associated underlying systemic disease, and many patients have associated ocular disorder. What is that ocular disorder that can be associated with your episcleritis, such as ocular rosacea, keratoconjunctivitis sicca, and atopic keratoconjunctivitis? These are the associated conditions with your episcleritis, right? See, unlike episcleritis, if you take scleritis, scleritis is very painful, destructive, and more often associated with underlying systemic disease, particularly like rheumatoid arthritis, Wegener's granulomatosis, tuberculosis, syphilis, and herpes zoster. So episcleritis, you don't have any underlying systemic disease, but scleritis, you have an underlying systemic disease like rheumatoid arthritis, Wegener's, tuberculosis, syphilis, and as well as the herpes zoster. Okay, right now, and if you have any doubt differentiation between episcleritis and scleritis, the best person to differentiate will be the ophthalmologist, right? So the point telling you that it is the episcleritis is that the patient is having hypertension but no other past medical history. Okay, so this is suggestive of your episcleritis, right? That is what, yes, Kwame Bempong. I said you right. In episcleritis, you don't have any underlying systemic disease, but in scleritis, you have an underlying systemic disease. That is one of the very, very important difference. Okay, right. Now, having discussed about that, you see the next question. Okay, the itchy papules shown here developed in a 27-year-old man after picking blackberries on a hot summer mid-afternoon. What probably caused them? Fleas, harvest mites, ticks, bees, mosquito. Right. So what are these? These are the chigger bites. These are the chigger bites, okay, which are nothing but the harvest bites, which are nothing but the harvest bites. Okay, now if you take this harvest bite, like which season they are very common. These harvest bites or chigger bites, they are very common in the summer. They are very common in the hot summer. Okay, and these particular lesions are caused by the bites of larvae of the trombiculid mites. Harvest mites are nothing but the larvae of the trombiculid mites. Okay, and these particular trombiculid mites or the harvest mites, when you see this word summer and with these particular lesions, go to your harvest mites, which is also called the chigger bites. Okay, right. And how do you treat these chigger bites? That is, you need to give because these bites, they have like severe itching. So how can you treat that particular severe itching or pruritic lesions? You need to give anti-pruritic therapy, right? You need to give anti-pruritic therapy. Then topical steroids, right? Then topical steroids. Okay, so these are the treatment options for your the chigger bites. Yes, Anusha Reddy. Yes, in Paget's, it is a high output heart failure because Paget's is what? Paget's is a hyperdynamic condition. So Paget's being a hyperdynamic condition, the Paget's will cause the high output heart failure. But in the recent days, in the heart failure classification, we are not using the word high output heart failure or low output heart failure. Heart failure, like we are classifying that based on ejection fraction. Heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So that is what we are classifying the heart failure. No more we are using the word high output and as well as the low output. Okay, right. Now last question. Okay, so this was asked in the recent NEET PG exam. Okay, now this pleural fluid was drained from a patient after a motor vehicle accident. After a motor vehicle accident. Similar pleural fluid may be associated with all of the following conditions except the options are pleural fluid triglyceride level of more than 100 milligrams per deciliter, moderate congestive heart failure, lymphangiomyomatosis, thoracic duct obstruction, normal serum triglyceride levels. The question asked is except. Very good. So what exactly is this? It is your chylous effusion. Right? It is your chylous effusion. So now chylous effusion, it is what? It's an exudative type of pleural effusion. Whereas in congestive heart failure, what you get is the transudative type of pleural effusion. So the the question asked is except. You don't get this chylous effusion in patients with the congestive heart failure. Okay. Now, what exactly will be there in the chyle? There will be triglycerides. And how much will be the triglycerides? More than 100 milligrams per deciliter. Right, more than 100 milligrams per deciliter. Now, there are numerous causes for chylous effusion. What are all the various causes of chylous effusion? What is the cause here? That is the trauma, right? That is the trauma, road traffic accident, right? Where there might be thoracic duct obstruction because of the trauma. We don't know, right? And then what are the other causes? You have a congenital cause also. Congenital cause is the thoracic duct atresia, right? Then the causes like pulmonary lymphangiomyomatosis and infections like tuberculosis, all these can cause. Okay, so lymphangiomyomatosis, the thoracic duct obstruction. Now, what about the normal serum triglyceride levels? See, the pleural fluid triglycerides will be elevated more than 100, but whereas the serum triglyceride levels, they may be normal. Then the treatment is the conservative management includes the pleural fluid drainage and restriction of the fat intake. Conservative management includes the pleural fluid drainage and restriction of the fat intake. And chylous effusions, whichever are resulting from surgical complications, are generally best managed surgically itself. So this is about your chylous effusion, and you don't get this in patients with a congestive heart failure. The question asked is except. Okay. Right, yes, that is what I am telling you, right? Yes, Venkatesh and as well as Bembo, Kunjay, right? So serum triglyceride levels will be normal, but the pleural fluid triglyceride levels will be elevated. Please remember this. Pleural fluid triglyceride level. So now how can you differentiate chyle? See, chyle can be differentiated from other fluids by its high pleural fluid triglyceride levels in the setting of normal serum triglycerides. Serum triglycerides will be normal, but the pleural fluid triglycerides will be elevated. That is what is your chylous effusion. Okay, so this is about some of the very important PYQs of the PYQ images which have been asked related to general medicine. So I'll be sending you this particular PDF on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can just join my channel wherein you can get this particular PDF downloaded. Okay, so thank you very much, and if you want any particular sessions, you can just text me on my Telegram channel. Yesterday I have discussed the ECGs because some of you have asked me to discuss ECGs, so that is the reason why I have asked ECGs. So any particular topic you want specifically to be discussed, please let me know. I'll be discussing those particular sessions. So thank you very much. See you in the upcoming sessions.